Welcome to the GAP MASLD MASH Community Network. I am Stacie Egan, nurse practitioner, Ogden Clinic in Ogden, Utah. I work closely with patients dealing with metabolic liver issues, and I'm excited to share insights about non-invasive testing and how we can use this to evaluate and get better treatment options for our patients. Take a minute and scan this QR code so that you can record your attendance for this meeting. So tonight we're going to start with a clinical case study. I think this is such a great way to actually learn how to diagnose and treat patients. So we're going to go through our patient. His name is Albert. He is a 65-year-old man with obesity who was referred to our clinic for elevated liver enzymes and an ultrasound that was remarkable for increased echogenicity concerning for steatosis. So Albert has a history of some alcohol use, but not since his early 20s. He has some lab studies, triglycerides 89, an HDL of 41, an A1C that's slightly elevated at 7.2%, an ALT with known elevation for 3 years of 1 to 2 times the upper limits of normal, which is concerning. Anytime you see these elevated ALTs, greater than 30 in men, greater than 20 in women, we need to be concerned that something's going on with the liver. We have notably worked him up for other causes of chronic liver disease, which is important anytime we're worried about metabolic associated steatohepatitis. So patient has type 2 diabetes, hypertension, hyperlipidemia. He does have some abdominal adiposity, no stigmata of advanced liver disease. And like I said before, he is obese with a BMI of 29. So this is a patient with metabolic syndrome. This is a classic patient with metabolic associated dysfunction as steatotic liver disease. Sorry, I'm having trouble getting my slides to progress tonight. So what we're going to start talking about tonight is non-invasive testing and how we can use this to effectively work our patients up for liver disease. So we've got a lot of options for non-invasive testing. We've got some imaging biomarkers of liver fat or steatosis. We can use ultrasound, MRS. We can get a CAP score from a FibroScan, and we can use MRI PDFF. So these are all good imaging biomarkers so that we can evaluate the steatosis a patient has in their liver. We can also do imaging biomarkers looking for liver stiffness. So shear wave elastography, ARFI, VCTE, or FibroScan, where you get the KPA, or you can use MR elastography. Other things that we can use for prediction of fibrosis, we can use a FIB-4 score, a NAFLD fibrosis score, APRI. These are all great tests to use because these are already labs that we're getting. So we can use lab values that we already have to work up patients and risk stratify them for MASH with fibrosis. There are some proprietary serum markers of fibrosis, notably the ProC3, the ELF, the FibroSpect, and the fibrometer. ELF is something that I use in my clinic, especially if I've ordered another test and I'm not quite sure where my patient is on the fibrosis scale. And then you can use some combined rules, FAST, MEFib, and MAST. So when you're thinking, hang on for just a sec, I think I might have skipped a slide. Okay, so now I'm off. Sorry, guys. I'm having challenges with the slides tonight.
If you want to just tell me when to go forward, I could do that for you.
Okay, so FIB-4 calculator. This is a great first test when we're trying to risk stratify our patients. You can see that these are values that we already have. It's a patient's age, their AST level, their platelet count, and their ALT. Now, you don't necessarily need to do math. Most of our EMRs will have some sort of calculator that we can plug these numbers into. If you don't have it on your EMR, I don't. There are a lot of good online calculators like MD Calc where you can go in and actually work up a FIB-4 for your patient. When you're thinking FIB-4, a FIB-4 score of less than 1.3 generally exhibits a high negative predictive value for excluding advanced fibrosis with or at risk for MASLD. Conversely, a FIB-4 score of greater than 2.67 indicates an increased likelihood of advanced fibrosis. When you get scores that are greater than or equal to 3.48, you have to worry more about cirrhosis. One thing that I would want to warn you about a FIB-4 calculator, I don't always take the less than 1.3 score that says high negative predictive value and just go off of that. If you have a patient that has a FIB-4 score that's less than 1.3, but they are a patient with other risk factors like type 2 diabetes that is uncontrolled, hypertension, hyperlipidemia, so they are a patient with metabolic syndrome, I will often do something like an ultrasound just to make sure that I'm not missing fibrosis. Um, I think that's important. I've had patients who've had a FIB-4 that is in that range below 1.3, and when I actually do additional testing, I do find that they have some F2 fibrosis. And so I think it's important to use our clinical decision-making skills and think beyond these tests, use them as a tool, but be aware of our patients and their individual metabolic conditions so that we don't miss patients with fibrosis. Thank you. So one of the proprietary serum markers that we can use is called ELF. And ELF is looking at direct measures of fibrosis and has a good diagnostic accuracy for advanced fibrosis. So you can see it's pretty sensitive. When it says that your patient has fibrosis, it's most likely that they do. And so this is a really good test that you can use with a FIB-4. Say that you do have a patient in that indeterminate range of the FIB-4 and you're not quite sure what to do next. This would be a good test to get that's just a blood serum marker. Things that I am aware of when I'm recommending an ELF test to a patient is that it might cost them a little bit of money. Sometimes patients are paying around $200. So I always do educate patients that they might want to call their insurance and figure out if the ELF test is covered. A lot of patients will get it no matter what, but I do like to make them aware of that. But this is a great test just to help figure out if a patient does have a chance to have advanced fibrosis. So when we're thinking about non-invasive assessment of liver fibrosis and we're thinking about elastography, what we're thinking about is the stiffness of a liver. So stiffness is the ability of an object to resist change in response to an applied force. So in a liver, it's actually bad if it's more stiff. You don't want that to be your liver. But when you're thinking about elastography, you think that shear waves travel faster through a stiff liver than a liver with less fibrosis. And so liver stiffness will increase with fibrosis stage, and that is why we can use elastography as a measurement of liver fibrosis. So vision controlled transient, oh shoot. Vision-controlled transient elastography, or VCTE, is, I call it FibroScan because that's what we have in our clinic. It's a non-invasive quantification of two physical biomarkers of the liver, and it doesn't take a lot of time. We have our patients come in, they can do it right in the clinic. It takes about 10 minutes, but we can look at three things with FibroScan. We can look at liver stiffness, so we can get a fibrosis score, and we can also get what's called the CAP score and look at steatosis. So when you're thinking about the new therapies for MASH with fibrosis, they address both fibrosis and steatosis. So these are biomarkers that help us to assess the disease severity in our patients with MASH, what their steatosis score and what their fibrosis score. And so this is a really great test to help us once they have that FIB-4 that we're concerned about. We can do this as a secondary test to see, do they have fibrosis? What is their fibrosis score? What is their steatosis score? And then we can make better decisions for treatment for our patients. There are some considerations that we have to take into account when we're thinking about VCTE. First, are we getting 10 valid measurements? Because that's important if we're gonna have an accurate FibroScan. Is the IQR median less than 30%, which means are your measurements all similar so that we know that we're getting a good reading on this patient? What is the image quality? What was the success rate of getting the 10 measurements that we need? And how experienced is the operator? Our FibroScan operators need to have the experience and the training so that they can do a good job. Your FibroScan is really only as good as the person doing it. So in my state, we can use an MA to do our FibroScans, and we do, but they are all trained extensively, so they know how to do a FibroScan, they know how to get the valid measurements that we need, and then a provider actually reads the VCTE exam so that we can know our patient's fibrosis score and their steatosis score. The limitations, patients that have an ALT or AST greater than 100, if your patient has cholestasis, if your patient is not fasting 3 to 4 hours before testing, the test won't be as valid. If they're currently using alcohol, the test won't be as valid. If they're morbidly obese with a BMI greater than 35, the test won't be as valid. Or if they have ascites or liver masses. So this test has limitations, and in our patients that are morbidly obese, have ascites, liver masses, or are currently using a lot of alcohol, we may want to choose a different imaging study to figure out their fibrosis score. And the MR elastography may be that test. MR elastography is a great test for fibrosis. It uses shear wave technology to figure out a fibrosis score on a patient. This is a better test for a patient who has a high BMI. So if you really are concerned that the BMI might affect your FibroScan, you may choose to order an MR elastography instead. On the slide, it does say considerations are BMI is one of them. That is more, can they fit in the machine? How big is the patient? And with a higher BMI, an MRE is going to take longer. So sometimes it's more difficult for patients because it will take longer to do the test. You have to consider if they have iron overload in the liver, that can change results. If they do have a non-MRI compatible implant, this is not the right test for them. If they have claustrophobia, this may not be the right test for them. Hepatic congestion, or if you don't have access to MRE. MRE is hard for me to get. I have to use a hospital to get this, so it's harder for me to order and schedule, and then a lot of times insurance doesn't want to cover because it's more expensive. But it is something that you can consider in the correct patient. This is just a great chart that talks about our non-invasive biomarkers of advanced fibrosis. Like I said before, FIB-4 is a really easy first test, and this is something that I'll talk to about with my primary care providers, because they already have these labs and they can help risk stratify the patients that need to be seen in our clinic. Below 1.3, we think of these patients as low risk. Above 2.67, we think of these patients as higher risk. And then that indeterminate area, we're not sure, and we do need to get a second test. Above 2.67, I get another test as well because I'm treating fibrosis in my clinic. If you're not the one treating and you're referring, you can always allow someone else to do the additional testing, but I usually get some sort of additional testing in any patient that I'm concerned about fibrosis. An ELF score can be a really good test, especially if you have some indeterminate measurements and you're not quite sure if your patient has F2, F3 fibrosis. Um, it is send out testing, like I said before, and there can be additional cost. Again, I just educate my patient that that might be something that they will have to pay for. FibroScan is easily accessible to me. And a FibroScan KPA less than 8, we usually consider F0, F1 fibrosis, and we end up watching them. I end up getting another FibroScan in a year, repeat labs. I don't stop watching these patients. Greater than 12, we have to consider, are they F3 or F4 fibrosis? We do have to remember that there are multiple potential confounders, and it does require an experienced operator. But this is a really great point of care test, and if you have access, it's a really great way to assess your patients for liver fibrosis. If your patient isn't appropriate for a FibroScan, or you have some indeterminate results from your other non-invasive tests, you can always get an MRE. It does cost more money. It's not as widely available, but it is highly accurate and a really great way to look at fibrosis in the liver. So we're going to go back to Albert, who is our 65-year-old male that we talked about before, elevated liver enzymes with that abnormal liver imaging, and he does have metabolic syndrome. So we do believe that he has metabolic dysfunction associated steatotic liver disease. We're going to do some additional workup on the patient because his FIB-4 was 2.22. So this is an indeterminate risk. We're not sure if our patient has fibrosis that needs to be treated or not. So what should you do next? You need to do another non-invasive test at this point, and one that's appropriate for the patient. We ended up getting a FibroScan, and Albert's fibrosis score was 6.7, which is low risk, F0, F1 fibrosis. So we're going to manage him with lifestyle modifications. So we're going to work on his A1C. We're going to work on his obesity. We're going to put him on a Mediterranean diet. We're going to start him on an exercise program with some weight-bearing exercise. I would get him to a dietitian. I love to use my dietitians when I'm treating these patients, because even if we were starting him on a medication for MASH with fibrosis, we don't just do this. We still have to do lifestyle modification. If our patients are drinking alcohol, we have them stop drinking. We have them work on weight loss, and then we plan a follow-up with them. We talk about the importance of making these changes so that we can hopefully halt the progression of fibrosis and maybe reverse some of the steatosis. On the right, there's a really good care pathway that can help us identify patients at risk and know what to do with them. So step one, we need to identify these patients. Do they have 2 or more metabolic risk factors? Especially type 2 diabetes, there seems to be a really strong correlation between type 2 diabetes and MASH with fibrosis. So diabetes, hypertension, hyperlipidemia, obesity, do they have those things? If they do, you should be considering MASH with fibrosis. And then if they do have any steatosis on any imaging and elevated liver enzymes, of course, we want to look further into this. So we'll take a history. We'll make sure they don't have any other causes of liver issues like excessive alcohol intake. They don't have something like autoimmune hepatitis. I always do a lab workup on these patients so that I know if I need to be worried about other things. If those things are negative, then we have a high suspicion for MASLD MASH, and this is when we can get the FIB-4. We can see if they're low risk, indeterminate risk, or if they're high risk. Like I said before, if they have a FIB-4 of less than 1.3, but you are really suspicious that they might have MASH with fibrosis, it's not wrong to get an ultrasound at this point, and I actually think it's the right thing to do. If we can identify and treat these patients early, they have better outcomes. As you go down on the algorithm, you can see with an indeterminate risk, we need to do another study. If you have access to FibroScan and it's the appropriate patient, it's a good idea to get a liver stiffness measurement. So if they end up like Albert with a liver stiffness measurement of less than 8, then we can repeat the non-invasive testing in 2 to 3 years, or use your clinical judgment. If you feel like this is someone that might progress more quickly, you can do more testing in a year. That's what I usually do. If they do have a moderate risk, a KPA of 8 to 12, they, you can actually treat these patients with our new um, drugs for MASH with fibrosis with a FibroScan. So if it's something that you're pretty sure of based on their other testing and their FibroScan, this would be a time when you could actually treat patients. These drugs are appropriate for patients with MASH with F2, F3 fibrosis. And in my community, I am the hepatologist. We don't have a hepatologist, so I am responsible for um, evaluating and treating these patients, and you might be as well. And if they're high risk, um, I keep them in my clinic. If you have to, you can refer them to hepatology at this point. If they are for fibrosis or cirrhosis, you do the regular things, ultrasound every 6 months, watching their labs. But F2, F3 fibrosis, we can treat in our clinics, and I encourage you to feel comfortable if you are the hepatologist in your community, because we have the clinical skills and our scope of practice allows us to do that. If you would like more disease state education, you can visit the GAP MASLD MASH Community Network for additional disease state education. And to watch a Resdiffer webcast, you can just scan this QR code. You can also scan this next QR code to complete a short survey and share your thoughts on today's presentation. Your insights help us to continue to improve our educational programs. I will open up to questions and answers now if anyone has any questions or comments. Thanks for coming tonight.